So this last part of the posture lecture is going to be about the specific types of injuries that we're going to see and the ways to assess those injuries or postural abnormalities. Starting off here, we just look at the overall body impression, or what the body type of the person is. I'm sure you guys have heard of these before: ectomorph, mesomorph, and endomorph. These are when you just look at somebody and you look at their general body type. Where, down here is a description. Your ectomorph tends to be someone who's very slender, thin in build, low body mass, small joint surfaces, not very large build in general. Where you have your mesomorph is more of your medium athletic type build. These people tend to generally build muscle very quickly. You're going to have medium muscle build, medium bone type, medium joint surfaces. So the medium kind of individuals, and your endomorph are your larger, stocky individuals. Probably a little bit slower metabolism, heavy build, heavier body mass index, large bone structure, large joint surfaces, more muscle mass. Your larger individuals in general. Coming back here to another way to look at someone's body type is through body mass index. This is an equation, your BMI. I'm sure you guys have heard of it. That uses height and weight in order to give you just a general number. And there are guidelines that are used to determine what the appropriate number is for males and females. So they use that number to determine, unhealthy weight, healthy weight, overweight, and severely overweight. So you want to make sure that you fall in the correct category. This is for the general population. So general people, the BMI tends to be pretty accurate. When you start looking at the athletic population, you have to be careful about using body mass index, because in order to calculate BMI, body mass index, we're only using height and we're only using weight. So this is based on a lot of normative data collected on just general people. When you deal with athletes in general tend to be taller and they tend to be heavier, but that heaviness does not come from actual fat mass, it comes from muscle mass. So we have athletes, both male and female, who tend to be a little bit taller and tend to be a little bit stronger, which means they're going to weigh a little bit more, so that their BMIs are going to show that they are overweight or even severely overweight, when in reality they're in very good shape. So you have to be careful about using things like BMI when looking at the athletic population. The average population, then yes, BMI is a really good indicator, easy way to determine where you're at. What's better for athletes is something like skin folds or body fat composition. We want to figure out how much of their body is actually fat, and we're able to do that through things like skin fold or bioelectrical impedance or hydrostatic weighing, different methods to assess fat composition versus just your height and weight. When we do the assessment, we want to make sure that we look at the person from all planes. So we want to look at them from the front, from the back, and from each side to get an entire idea of what's going on in the person, because if you only look at them from one angle, you might actually miss something. So these next couple pictures and slides look at someone who is standing in ortho position next to a plumb line. Now, we are going to do this in lab next week, but this description here is where the plumb line should cross. So when looking at lateral posture next to a plumb line, we want to start the person. So I said earlier that you want to work in a systematic order, and I said I like to start at the feet. So we stand the person next to the plumb line, and we want the lateral malleolus to be slightly posterior. So if we put the plumb line here and it's hanging there, we position the lateral malleolus slightly posterior to the line, slightly behind the line. And then from there, we don't tell them anything but to stand in their normal posture. This is where the plumb line should go. It should be in front of the malleolus. It should cut through the middle of the tibia, go to the lateral femoral condyle, should go through the greater trochanter, through the mid-thoracic region, through the acromion process, through the cervical spine, and then through the external auditory meatus, which is your ear canal. So that's what ideal posture is when looking at the person laterally. But the big thing in here is, in order to figure out what is ideal, we have to work in a systematic order, make sure that their feet are lined up with the plumb line, and then see where they go from that position. Same kind of thing here, looking at them from the anterior position. we want the plumb line to bisect each of their feet, so we want it between their feet as much as possible, and then basically it should cut them into right and left halves. We can look at him and see that his nose is a little bit to the side, so he is somewhere along the line. He is deviating from this normal up and down. And again, you don't have to memorize these, but you do need to know when you are doing an assessment that that's what you're looking for. Also anteriorly, you kind of want to get closer. Make sure that, again, you're looking at eye level if it requires it, but there is going to be some palpation involved in here as well. So we would like to actually go in there and palpate the heights of the iliac crest. So palpate the iliac crest and keep your hands on there, and then you're able to see from a distance, from where your hand, reach your hands out, and see, are those iliac crests actually the same height. Same thing here. She's palpating the ASIS and determining if the thumbs are the same height, and then the shoulders at the AC joint, are the shoulders the same height. So you actually are getting in there and palpating as well as assessing the levels. Posteriorly, same as anterior, we want the plumb line to be in between the person's feet, and then shoot straight at the back all along the entire cervical bodies, or I'm sorry, the entire vertebral bodies. And again, here is your checklist of where it's supposed to be. Posteriorly, because we are in upper extremity, so we are going to look more at the shoulders, we want to look at what the scapula are doing. We know the motions of the scapula. We have elevation, depression, protraction, retraction, rotation, and then something else called winging scapula, which I'll get to in a second. But we're able to determine how much of a certain motion they have, and is that motion normal. So we can actually assess elevation, depression. In the normal person, the inferior angle of the scapula, the pointy part at the bottom of the scapula, that usually lands between the 7 through 9 thoracic vertebrae. Now again, I know it's kind of difficult to actually palpate the exact number you're on, so if nothing else, if you don't know what 7 to 9 actually means, you can at least palpate both inferior angles, and you can see that if they're even. If we have one inferior angle down here and the other one up here, we know that this scapula is going to be elevated and possibly anterior tilted. So we know it's not right. So if they're both even, we would like to know if they're between 7 and 9 thoracic vertebrae, but if nothing else, are they at least both even? That'll give you your elevation, depression. Are they the same bilaterally, or are they different? Protraction, retraction is something that we're going to want to look at, because forward shoulder posture is definitely about protraction. Retraction is usually more about muscle spasm and things like that. We definitely see way more protraction than retraction. Normally speaking, we want to measure, we can use this regular tape measure, and we can go from the spinous process over to the medial border of the scapula. So ideally we'd look at the T3 spinous process, but you try to find, the medial border is somewhat curved, so if you try to find the more prominent part of the medial border where it's kind of sticking out the most, right by the spine of the scapula, then you can measure it from the medial border to the immediately over spinous process, and normally that's about 5 to 7 centimeters. The first thing you want to do is measure both. Are they the same? And then you want to look at, is it in that 5 to 7 centimeter range? And that will tell you if both sides are protracted, only one side is protracted, both sides are retracted, and what's actually going on. So you can compare them to each other, and you can compare them to the norm. You can do the same kind of thing for scapular rotation, although I cannot find any normative values for what is considered normal. But instead of measuring up here like we did for protraction and retraction, we're actually going to measure down here at the bottom. So we find the inferior angle, mark it, then go over to T7, which should be the next vertebrae over. We measure that distance. We compare them to both sides, because if this scapula, which is kind of right in here, if it was upwardly rotated, then the inferior angle would be more like this. So you'd be further away, which would give you a longer distance. So because I couldn't find any normative values in the book or whatever, you're just at this point going to want to compare them to each other to see, are the values of both sides the same. Then you can determine if one side is upwardly or downwardly rotated compared to the other. Winging scapula is a separate, it's not really a, it's a posture, it's kind of an injury, not really something you're going to measure. But what's going on here is your scapula actually wing off the back of your rib cage. The medial border actually pops off. It's the job of the serratus anterior. You're going to want to know that muscle. The serratus anterior's job is to basically lock down the scapula to the thoracic wall. For whatever reason, when you have a winging scapula, your serratus anterior is not working appropriately, whether it's because it's weak or because the nerve is damaged and it's not working correctly. Whatever the reason, if it's going to cause the scapula to wing off. And this is a big problem because if the scapula is not stabilized, your entire upper extremity is not stable. You can think of the scapular stabilization like core stabilization. You've heard probably a ton of times that you're only as strong as your core is. I don't care how much you can curl on the curl machine, bicep curl. If your core is not strong, you're not going to be functionally strong. The same thing goes with your scapular stabilizers. If your scapula is not strong, then your entire upper extremity is not going to be strong. So you can't expect to do powerful motions if your scapula is not stable and is winging off the back. And I think we'll talk more about that a little bit later. I'm not sure. Common postural deviations. Not all postural problems are going to cause a pathology. And we don't always have to fix postural problems. There are going to be things you're going to find. Now that we're going over a lot of posture, you're going to catch yourself looking at people walking in front of you, and you're going to notice a lot of weird postures. And they're not all bad. Now, they're not all symptomatic. So our goal is to determine which postures cause the problem, and then which postures do we think could possibly cause a problem in the future that we may want to address. But not all postural deviations are a pathology. One postural problem is flat feet. People have fallen arches, people have pes planus, and if we try to fix every person or put every single person with flat feet into orthotics, we'll probably end up doing more damage than we would good, because over time your body is going to compensate and start dealing with and getting used to these postural deviations. So if we go all of a sudden fix this postural deviation that the person's had their entire life, it may actually end up causing an injury or cause more pain than if you just left it alone. So you got to kind of pick and choose what you think you want to fix. Generally speaking, forward shoulder posture is pretty bad. Especially if you're an upper extremity athlete. Again, tennis, volleyball, baseball, softball, where you're actually doing things overhead, possibly swimming. If I was in charge of, the baseball team and I saw an athlete with forward shoulder posture, even though he wasn't complaining of pain at that point, I would probably harass him into doing some rehab for his forward shoulder posture, because there's a good chance that I would see him again in the future with a shoulder problem. So we're trying to fix it before it becomes an issue. But there's plenty of things out there that are completely asymptomatic, where they don't have any symptoms, that you really don't need to address. So specific injuries we're going to talk about. Again, I know this is upper extremity, but it's all kind of connected. So we'll get this now. You'll get this again next semester. I think you get the same PowerPoint again next semester. But you have hyperlordotic posture, kyphilordotic posture, sway back posture, flat back posture, and scoliosis. So also when we get into this, think back to when I was talking about how the different muscle groups are related. So again, the person with the lumbar lordosis, how some muscle groups were tight and some were weak, that will come back into play here. So it'll help reinforce that idea. So the first one is like I was talking about previously, the hypolordotic posture. So here's your plumb line, and you can see that this person has that increased lumbar curvature. There is an increase in curve right here. So what we have is his pelvis is actually rotated down like this and has rotated up like this. So his pelvis has turned, and that means his spine kind of looks like this. So we see a big kind of dip right here. He has, it's called hyperlordotic curvature. There's going to be an extra curve. The top is relatively normal. The lordotic curve is extra anterior. Just like before we said, it's about the cross muscle. So if we look over here, what we see, the potential cause of this problem is tightened or shortened hip flexors. So these over here. and tighten or shorten back extensors. So again, they're both on the same line. They're going to be together. Those are both going to be tight. And or weakened elongated hip extensors, which are back here, and abdominal muscles. A lot of times these people have weak abdominal muscles. So again, if I was addressing this person, I would want to strengthen the weak muscles and stretch the tightened muscles. Overall, a lot of these postural people, we're going to have the term poor postural sense. And this is just, when you stand, you should be contracting your muscles. If you stand and you're in good posture, your body is not locked out, like your knees are not locked out, your hips are not locked out, you're not sticking your stomach out, you're not relying on your spine to keep you upright. When you're in good posture, all of your joints are slightly flexed, and that means you're using your muscles to hold you in place. What poor postural sense kind of means is you're not using your muscles to keep you upright. You're relying a lot on your joints connective tissue to kind of keep you upright, and because of that, you're putting a lot of stresses on things that shouldn't have a lot of stress. If you're relying on your joints for support versus your muscles for support, your joints are not designed for it, your muscles are designed for it, so you're going to end up just wearing those things out and causing a lot of pain. Kypholordotic posture is the combination. So when we say kyphosis, we're talking about this posterior curve, where lordosis is anterior curve. So when we look at this person, the general normal spine, we have a lordotic curve in the cervical spine, a kyphotic curve in the thoracic spine, and a lordotic curve in the lumbar spine. So that's normal. The spine is supposed to be curved for a reason. The spine is curved so that we're able to actually dissipate force, so that we can get rid of force. If it's curved, we're able to get rid of force easier than if it was straight up and down. We don't want straight up and down. We want it to be curved, but we don't want it to be too curved. So in this case, kypholordotic posture, we have excessive kyphotic curve and excessive lumbar curvature. So we have things going on in both areas. Overall, muscle imbalances, same as we saw before in the lordotic area, as well as poor postural sense. This guy also has this plumb line supposed to be over here. So he's got kyphosis, and he's got forward shoulder posture, and a little bit of forward neck posture, or forward head posture. So there's a lot of things that we need to fix, but a lot of it would come down to training him to be conscious of his posture. If we train the poor postural sense, and they actually become conscious of it, and they start to stand up straight, then that's going to help a lot of things. This posture is one that I do really like, because this person reminds me of a good friend of mine. This sway back posture. In this posture, like I said before, normally when you stand, you want to have your body slightly flexed, so you're not relying on your joint capsules to keep you upright. Well, in this person, they're pretty much solely relying on joint capsules to keep them upright. You can see back here. You can see back here the knees are all the way locked out. So we have a big severe angle over here. So she's using the posterior joint capsule of the knee to help keep her upright, versus flexing the knee a little bit and using the quads and the hamstrings to stay upright. She's using posterior joint capsule. Then we see another line come this way, and the pelvis is now sticking out. Now we're using the anterior pelvic, the anterior hip capsule to support. So then we're going to see this way, the back's going to come over here. Now we're going to be using a lot of the back structures. We're going to be relying a lot on the spine to keep her upright. And you're going to see another one over here to kind of finish things off in the front. So it's a very severe posture, and it comes down to general muscle weakness and poor postural sense. This person in general is not usually very strong, and they just, if you can stand like this, if you stand up straight and just totally let your body relax right before you fall to the ground, you lock your knees out, you lock your hips out, you use your back to keep you upright, and your head is forward. But because of all this, she's able to stay upright but not using muscle. So the big thing here is definitely increase muscle strength as well as increase the poor postural sense, and you'll see major differences. Flat back posture is basically the opposite of lumbar lordosis. instead of having an increase curvature like we saw before, we have a decreased curvature. With the lumbar lordosis, we saw an increase in anterior curvature, which means an increase in anterior pelvic tilt. So in that person, in order for the spine to be over here, we had to tilt the pelvis forward. Now in this case, because again, they're all connected, in order to get the decrease in lumbar curvature, you can look that this back is very flat. The spine is not curved in the lumbar area. We actually have a posterior pelvic curvature, where instead of going forward, it's going backwards. We still can use this whole line idea, but now the muscle groups are going to switch. So because we have a posterior pelvic curvature, that means these are going to be pulling back. So the hamstrings are tight, the abdominals are tight. Now in this case, the hip flexors are going to be weak, and the back is going to be weak. So it switches. It's going to be the opposite of lumbar lordosis, but the exact same concept, but in the opposite direction. Then we have scoliosis. Scoliosis is defined as the lateral curvature of the spine. It's important, if you write down any short answer, don't say scoliosis is the curvature of the spine, because the spine is already curved. What we mean here is that scoliosis is a lateral. So this is normal. This is a lateral curvature. So make sure that you say lateral curvature, because again, the spine is already curved. But that's anterior to posterior. The spine should not be curved lateral in any direction on either side. So there are two different types of scoliosis. One is structural, one is functional. The structural problem is the actual structures are not right. So when you were growing, you had one vertebrae here, one vertebrae here, and then we had this vertebrae that was kind of formed like this. So then the next one stacked up normal over here, and the next one was over here. So that's going to cause your curvature, because one of these vertebrae were misformed. That's a structural problem, because one of the structures is not correct. We also have a functional problem, and the functional imbalance is generally a result of a muscle problem or a leg length problem. So in this case, in this picture, the spine is being pulled to the right. Most often that's because these muscles are really tight, and these muscles are not strong enough, or they're weak. They're not strong enough to pull the spine back into alignment. So ideally, these two muscle groups on each side of the spine are equal. In this case, the right side is a lot stronger, the left side is a lot weaker, and now we see a lateral curvature. Or it could be sometimes a result of leg length. Again, that's the whole closed kinetic chain thing. If it's a leg length problem, it could end up seeing that up through the spine. We are able to tell the difference in our clinic between structural and functional. So when the person is standing up and we're assessing their posture, we identify a lateral curvature to the spine. We want to now know if it is structural or functional. If it is functional, we can try to address the problem. If it's structural, we're going to have to refer them, because we can't do anything about it. So the big fancy test to figure out if it's structural or functional is to have them bend over and touch their toes. And you may have actually done this, I had to do it back in grade school to get my back checked in class. It was strange. Bend over and touch your toes. If you have structural scoliosis and one of the vertebrae are actually the problem, your spine will still be curved when you bend over. If you have functional scoliosis, when you bend over and touch your toes, your spine will actually straighten out while you're bent over. So functional, because it's a muscle imbalance or leg length problem, your spine actually straightens out when you bend over. If it's structural, it'll stay curved. Then we mentioned, I think some of this before, some of it is forward shoulder posture. Forward shoulder posture is when you actually move the scapula around. It's going to be protraction elevation of the scapula, and then you're going to actually round your shoulders. It's going to end up changing the resting position of the shoulder. And there's a picture on the next slide. And then I already talked about winging scapula. This is when the medial border actually pops off the wall. And again, it is about the serratus anterior muscle and some of your middle lower trap, maybe even some rhomboid that are all weak, allowing that to happen. So here's a picture of your forward shoulder posture. it should cut through the acromion. The acromion is going to be out here in this case. Her spine's relatively straight. We do see a little bit of increase in kyphotic curve here, but her shoulders are forward. And if we were to measure this, we would find that the medial border of her scapula is pretty far away from the midline. So that 5 to 7 centimeters that's supposed to be normal, that's going to be more. Because in order for us to put our shoulder out here, our scapula has to move out. Generally, again, this is going to be a result of tight front muscles. Usually in the front, your pec is going to be really tight, your pec minor is going to be really tight, and your very weak back muscle. So instead of having an X here, it's just the front is tight, the back is weak. So you have a weak rhomboids, weak trap that are not pulling in the back, as well as that overall poor postural sense. So you just have to make sure, stretch the front, strengthen the back, and then teach them how to stand upright. We also have forward head posture. This is just an anterior displacement of the head relative to the rest of the body, where, again, this is supposed to, it does cut through the acromion right here, but it's supposed to go up the cervical bodies and into his ear, and that's not what happens because his head is forward. A lot of times we see forward head posture along with forward shoulder posture. Sometimes, like in this picture, it can happen alone. Potential causes could be wearing bifocals. You could be, not seeing very well, where you have to squint and you kind of stick your head out and squint. General poor postural sense. For whatever reason, the same kind of things going on here. We need to be able to pull their neck back. So work on the flexors and extensors, getting that head back into the right position. So overall, the last slide here, summing everything up, there is a lot of relationships between posture and biomechanics, but really the big thing is we don't know what happened first. Did the person have muscle tightness, which end up causing the postural deviation, or did the person have a postural deviation and then they had that postural problem for a long period of time, so the muscles just responded and became shortened? We really don't know which one came first, the muscle problems or the postural problems. But either way, we need to address both. So you're going to want to teach them the proper posture. Make sure that you get them in the proper posture, using their muscles to keep them upright, giving them reminders. It's just a constant thing. In order to change a habit, it's very difficult. So it's something you constantly have to be doing. And at the same time, you need to be working on the muscles that are there to keep you in the proper posture. So finding out which muscle groups are weak and strengthening them, finding out which ones are tight and stretching them out. All that, we just want to balance. Your body wants to be in balance. Your body wants to be in good posture. Your body works the best when it is in good posture, and when it's not, you're going to put yourself at a lot higher risk for injury. So posture is a big deal, and being good at postural analysis will get you a long way when it comes to specifically the rehab process.